Hello, my name is Roger Henderson. I'm a GP in South West Scotland, and I also co-host the GP Notebook study groups. Welcome again to this GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. Now you can find us on all major podcast platforms, including Spotify, Apple Podcasts and Google Podcasts, so do please follow us to receive notifications about new episodes. And if you like what you hear, and we really hope you do please consider leaving a review to help other listeners find us. You can also follow us on Twitter at GPnotebook for more information about new podcast episodes and study groups. Finally, you can visit GPnotebook.com for podcast episode show notes and to find out more about our upcoming study group meetings, which occur all year round. Now, in this episode, we'll be discussing Raynaud's phenomenon, and I always see quite a number of cases of these during cold snaps or during the winter months, although these can occur all year round. Now, named after Maurice Raynaud, a Parisian physician in the latter half of the 19th century who first described it in 1862, Raynaud's phenomenon, often just called Raynaud's, is a condition that affects the circulation of blood in certain areas of the body, most typically the fingers and toes. It can cause the areas to become painful, numb, and restrict movement, and they can also change colour, and they go white, blue, and then red in an attack. Now, it's characterised by episodic attacks of digital vasospasm and ischemia on exposure to cold, or, less commonly in my experience, emotional stress. And this causes the characteristic triphasic colour changes in the extremities that we see. So white is ischemia, then blue, deoxygenation, and rewarming with a slow blood flow, and then red, as normal colour returns during reperfusion. Now, not all of these three phases are needed to make a diagnosis, and an attack may last from minutes to hours. I've found that patients often complain of tightness in the first two stages and then a nasty burning pain which can be significant in the reperfusion stage. So the disease may occur as primary or idiopathic Raynaud's phenomenon, and this comprises the majority of cases, probably around 90%, and secondary Raynaud's phenomenon, which is due to some underlying condition such as systemic sclerosis, SLE, atherosclerosis, hypothyroidism, or vasculitis, for example. Now, primary Raynaud's, if we look at this first, it's more common in women and typically develops at a young age in the second or third decade compared to secondary Raynaud's. Now, we don't fully understand the cause, but we do know that vasospasm is a normal reaction to cold or temperature change, but in primary Raynaud's, this is exaggerated. And it may be due to genetic factors causing dysfunction in thermoregulation, which then leads to extreme vasoconstriction. Now, when we've looked at meta-analysis of observational studies, these suggest a primary Raynaud's prevalence of between 3 to 5% in the general population. But in non-population-based studies, 3 to 12% of men and 6 to 20% of women report symptoms of Raynaud's phenomenon. The main risk factors that we've identified for primary Raynaud's are being female, having a family history of the condition, a history of migraine, and smoking. In men, smoking and hand-arm vibration syndrome also appear to be significant triggers. Now, it generally begins, as I say, during the teens and the early 20s and isn't usually associated with any other disease entity. And one of the key points to remember about primary Raynaud's is that there is symmetrical involvement with no tissue necrosis or gangrene. Both ESR and anti-nuclear antibody testing is normal, and there are normal nail fold capillaries. By contrast, secondary Raynaud's often develops at an older age, by which I mean 30 to 35 and above, and particularly in men. And it's often the initial manifestation of an associated underlying connective tissue disease. And this occurs in 90% of patients with systemic sclerosis and up to 40% of patients with SLE and idiopathic inflammatory myositis. So some of the features that make a secondary cause of Raynaud's more likely include symptoms all year round rather than just in the cold months, digital ulceration, significant pain and discomfort, abnormal nail fold capillaries, asymmetric upper limb pulses or bruits, puffiness or tightness of the fingers, and a raised ESR and positive anti-nuclear antibodies. Now, we diagnose Raynaud's clinically, and this requires a number of points we should be covering during the history and examination. So I would suggest you focus your history on the location, and obviously the fingertips or the tips of the toes are the most commonly affected, and a clear demarcation of colour change that's usually circumferential around the digit. There should also be cyanosis and or rubor on rewarming. And remember, it is entirely normal for digits to turn mottled or cyanotic in the cold, so pallor should be present to make the diagnosis here. Take an occupational history and specifically ask about the use of vibrating tools at work or at home. And always remember to ask about medication, including over-the-counter or complementary preparations, and always ask if anyone in the family has the same problem. Now, when we come to physical examination, this should include an overview of general health, taking the blood pressure, and if this is asymmetrical Raynaud's, check the blood pressure in both arms. Also, check the upper limb circulation to identify any arterial occlusion, as well as looking for signs suggesting secondary Raynaud's, such as digital ulcers. And I always try to remember to check the skin as well for evidence of any connective tissue disease by looking for things such as telangiectasia, a malar rash, splinter hemorrhages, and alopecia areata. Now, unfortunately for all of us, in primary Raynaud's disease, there's usually nothing to find on examination because patients rarely present during the actual event. Now, the patient's age and sex usually influences the likelihood of the patient having primary or secondary Raynaud's, and in most cases, taking a good history and physical examination are sufficient to make a good working diagnosis. So in classically presenting primary Raynaud's in a patient who's well and you haven't found anything else on examination, you're unlikely to detect anything on investigation. But personally, I would always check a full blood count, anti-nuclear antibodies, and CRP, ESR, and plasma viscosity in this situation as basic screening for unrecognized associated diseases. I'd also refer it to a rheumatologist if I was suspecting secondary Raynaud's or if things like digital ulcers are present. I'd also refer if the diagnosis is in doubt, if I was suspecting a secondary cause, if I thought the cause was job-related, certainly if the patient was under the age of 12, or if the patient's symptoms remained poorly controlled despite appropriate conservative management. Now, when we go on to talk about the management of Raynaud's, this does vary obviously from patient to patient depending on the disease severity and symptoms. But as a general guide, the treatment for primary or even very mild secondary Raynaud's usually consists of lifestyle changes and pharmacological therapies, whereas treatment for moderate to severe secondary Raynaud's may warrant additional pharmacological therapies or even on rare occasions surgery if patients have progressed to digital ulceration or gangrene. So the lifestyle measures I'd always talk about would include keeping warm and avoiding the damp or the cold, and this can include wearing gloves when taking things out of a fridge or a freezer and using hand warmers. Moisturizing any dry skin is important. Quitting smoking is essential. And avoiding injury to digits and vibration exposure, as well as avoiding stress, that's important as well. And when we look at medication, we must always avoid vasoconstrictor drugs and any drugs known to exacerbate Raynaud's. And beta blockers are probably the big ones here. But we should also not forget things like ergotamine, clonidine, cyclosporine, and then caffeine can do the same thing. And recreational drugs include cocaine and amphetamines that can also worsen it. If patients then don't respond to simple lifestyle measures, we can then consider pharmacological treatment. And we sometimes forget topical treatments. And although the evidence on topical nitrates is limited, some studies have shown that topical glyceryl trinitrate applied to the dorsum of the finger does cause vasodilation there, with fewer systemic side effects than with oral nitrates. And this can occasionally undoubtedly reduce the severity of Raynaud's, but unfortunately not the duration or the frequency of attacks. If we then look at systemic agents, non-cardioselective calcium channel blockers are the most widely used oral treatment here in treating Raynaud's, as these promote relaxation of vascular smooth muscle cells and can lead to vasodilatation. Nifedipine is the most commonly used here, and typically at an initial dosage of 10 milligrams once daily, and we can increase that dose gradually to 10 milligrams twice daily after a week, and then gradually up to 20 milligrams twice daily to a maximum dosage of 20 milligrams 3 times a day if tolerated. Now, patients can report side effects with these, such as headache, dizziness, flushing and ankle swelling, but if they do that, try using a slow-release preparation, which is what I always prescribe in these cases and often minimizes them to the point where the patient is happy to continue taking them. I think it's important to say here there's a lack of evidence for the use of any other vasodilators other than calcium channel blockers in Raynaud's here. What's sometimes forgotten is that in patients with severe secondary disease, then PDE5 inhibitors such as sildenafil, tadalafil, vardenafil and sildenafil can be used when calcium channel blockers have failed or aren't tolerated. And prostacyclins, particularly iloprost, sometimes in combination with PDE5s, can be used to treat complications of severe secondary Raynaud's, such as threatened digital loss due to ischemia and digital ulcers. Surgical intervention can be considered for severe and disabling symptoms, but there's limited evidence in support of this, although for patients with secondary Raynaud's who've progressed to digital ulceration or gangrene, then surgery obviously may be required. Fortunately, primary Raynaud's is typically benign, non-progressive and doesn't cause tissue damage. The frequency and severity of symptoms does fluctuate with changes in daily temperature and obviously are worse in the colder months, but may gradually ease or even go into remission with increasing age, with about 50% of patients improving over time. Unfortunately, about 13% of patients later develop an underlying disorder such as scleroderma, and in secondary Raynaud's, ulceration, scarring or gangrene occur in just over 15% of people secondary to systemic sclerosis. So that's a reminder about what to be considering the next time you see a patient presenting with Raynaud's, and I do hope you found this reminder helpful. But have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. Do feel free to get in touch via social media at GPnotebook or email support@GPnotebook.com if you have any questions, comments, or ideas for future podcasts. We really do like to hear from you. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups and to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you for listening and goodbye.